My name is Amalia Weber. I'm the program specialist here at Rochester Hills Public Library, and I'd like to welcome you to this evening's program, Women's Health, Healthy Transitions with Henry Ford Health. Before we get started, I'd like to take care of a few housekeeping details. Firstly, tonight's program will be recorded and available to view about 1 week from tonight on our YouTube page and on the RHPL website shortly after. We ask the audience members please silence or turn off their cell phones before we begin in order to avoid any disturbances during the presentation. The 9th annual Friends of RHPL Wine, Wit, and Wisdom fundraiser takes place Saturday, April 26th from 6 to 9:30 p.m. Attendees can choose from presentations on coffee, local history and culture, space exploration, and forensics, and enjoy a buffet dinner and drinks, including wine, beer, and soft drinks, a silent auction, and a 50-50 raffle. Tickets are $80 or $90 after April 14th and can be purchased online at rhpl.org/friends or in person. Registration forms may be picked up at the circulation desk and can be dropped off in the Wine, Wit, and Wisdom box on the circulation desk, along with a check made out to Friends of the RHPL. Our next program is Electric Cars, Past, Present, and Future, which will be an in-person event on Thursday, March 20th at 7 p.m. You can sign up for that at calendar.rhpl.org. Now, without further ado, please welcome our presenter, Nancy Mattoni.
I'm a women's health nurse practitioner. I got my undergrad at University of Michigan and my grad degree at Wayne State. I have been a women's health nurse practitioner for nearly 25 years, was one of the first nurse practitioners to come into the area, and I've worked in a gynecology practice till about 2016, and then I'm now working in 2 different primary care practices doing their women's health. So I deal with the whole lifespan, but I found that I seem to attract women who are kind of my age or significantly younger, just because I have gotten older and I've gotten a little bit of experience as far as menopause. I'm going to give an overview of the transition through menopause and cover some of the issues. I've already heard a couple of you say that you have specific interest in things like osteoperosis, those kinds of things. I'll touch on that briefly, and I'm going to allow some time for questions and answers afterwards so we can delve into your more specific information and interests from there. But I wanted to give a general overview. There's a lot of information out there. So we're going to touch on a couple of things: the transition, what's impacting us, signs and symptoms, hormone replacement therapy, some of the adverse effects of going through menopause, like osteoporosis, like issues with sex, like a whole bunch of different things. So feel free to interrupt or ask questions as we go through, or if you need clarification, but let's go ahead and just begin, because this is a new season for many of us. Menopause isn't just about hot flashes, night sweats, the last period. Basically, it has a lot to do with how we transition, our life experiences, what's going on in our life at the same time, and how we're going to address things. Mental health, breast health, bone health, risks of cancer. We'll talk about all of that because a lot of it impacts us as we get a little bit older. And each of us goes through this entire process in a very unique way. So many women will say, well, my mom went through menopause when she was 55, or my sister was 46. It doesn't matter. We're going to all approach this and go through it differently based on what we've experienced in life and where we are in life. So I want you to keep that in mind. Perimenopause is basically a span of time where the ovaries are trying to figure out what the heck they're going to do. Are we going to work? Aren't we going to work? What's happening and what we need to do about it. The span, or typically perimenopause, can last anywhere between 45 and 55. The transition itself with hormonal change many times can be 5 years or so, where we're going through sometimes some very subtle changes and then maybe some more significant changes that we become aware of. So keep that in mind. Average age of the last period, 52. Again, give or take, everybody's a little bit different. Premature menopause is considered to be before age 40. And certainly sometimes we have premature surgical menopauses based on possibly a diagnosis of cancer, things like that, that can impact, again, on how we transition and some of the health issues that are impacted by that early transition. Some of the things that we may experience as we begin to transition through perimenopause are changes in our menstrual cycle. And it can vary. Some women, all of a sudden, their periods are getting heavier, the periods are longer, we've got clots, we've got cramps. Other times we're missing periods, the periods get lighter, everybody does something different. And many times early on in the transition, the response is very subtle, so we don't always know. Usually I'll say if you're at that point in life, you want to maintain some kind of a menstrual calendar, or at least use one of the apps that are out there so you can identify, okay, am I noticing some irregularity, or what do I need to do about it? Many times as the period begins to change, we have different bleeding cycles. I want you to be aware, though, that I usually would love women to go through perimenopause into menopause by the period's getting lighter, we're skipping periods, the period stops. Many women will in fact begin to have very heavy bleeding, clotting bleeding, as I mentioned. Those kinds of things you want to address with your healthcare provider, because sometimes it could be perimenopause, but other times there are issues that we need to address in a little bit more detail. For example, it could be that you have a fibroid uterus, you could have a polyp, you could have a cancer. Those are things we don't want to overlook just because we think, oh, this bleeding is just because you're going through perimenopause and moving on through. So do keep that in mind. Certainly during this time there's a decline in fertility. Typically we don't consider women through menopause until they've gone a full 12 months without a period. So obviously, even though you've gone 11 months and you're not quite at 12 months, you want to make sure that you're protecting your fertility for a period of time and considering some contraceptive method, or be aware you can have one of those weird ovulations and decide, whoops, do we want to have a baby when we're 55? No, so keep that in mind. Address that and consider that. And a lot of times what I'll say too is, you may have gone a full 12 months without a period. You may want to have some hormonal testing that's going to tell us specifically, yeah, the estrogen level is bottomed out and the follicle stimulating hormone has shot way the heck up. So yeah, you're official, and you can now not pay so much attention to condoms or birth control pills or IUDs or whatever else you were using in the past. What about hot flashes and night sweats? That sometimes is a key to, okay, we're experiencing some changes now. A lot of times what will happen with perimenopause, because it's such an erratic time as far as ovarian hormones, sometimes the ovaries are like, yeah, I want to work, I want to keep going, Custer's last stand kind of a thing. And other times it's like, yeah, I don't really feel like doing that this month. So you may have very intermittent hot flashes and night sweats, which is usually the primary symptom that women will report to their physician. Okay, I'm hot all the time, I can't sleep, I'm changing my sheets in the middle of the night. Many times during perimenopause, you will experience those symptoms, usually with missed periods, because you're not ovulating, and ovulation usually is associated with a menstrual cycle. So what can happen is you might have 3 or 4 months of, oh my gosh, and just when you decide to go to your doctor finally, you have a period and the symptoms go away. And you might have a couple more periods and everything is fine, and then all of a sudden it kicks back in. So you have this very erratic response to that fluctuation in the ovarian hormones. What can we do about it? A lot of times initially we ride through it. Many times for women going through perimenopause, if the symptoms are significant enough or the bleeding very erratic or heavy, I consider sometimes a low dose contraception, which I can eliminate your periods, and I can give you at least a little bit of estrogen and progesterone to minimize your symptoms as we transition. And a lot of times women will stay on that until, at some point we say, why don't you stop and let's just see if you're going to have a period. We might be done here. So keep that in mind as an option. There are also symptoms as we transition through menopause, and more so into menopause itself. We have what we call GSM, or genital urinary syndrome of menopause, and basically this is associated with a lack of estrogen that begins to impact on the vaginal tissue, the labia, the vagina, the vaginal opening, the bladder, the urethra, all of that. And as the tissue thins, we many times will have an increase in urinary frequency. We might have more urinary tract infections. We might have more vaginal dryness. Sex might be a little bit more uncomfortable. We might need to all of a sudden start to consider using a lubricant, those kinds of things. So again, we need to address that, and the sooner the better. Some of those symptoms may get a little bit better as we transition through. Typically, these symptoms, if you develop them, only get worse as we progress and get a little bit older, unfortunately. But we have therapies that we can use to manage the symptoms and make life a lot better. Urinary symptoms, as I mentioned sometimes, and you've heard maybe, especially as women get older, that they get confused, and sometimes in an assisted living situation, all of a sudden they're confused and they'll go ahead and check to see that they have a urinary tract infection, and they do. A lot of times that's associated with the thinning of the tissue again, and the shrinking of some of that tissue, which predisposes bacterial invasion, and they're more predisposed to urinary tract infections. And that can sometimes happen to women postmenopausally as that estrogen impact on those tissues becomes more apparent. So again, we address that easily. Managing weight. We're always trying to manage weight. I don't know that it's always menopause, but bless God's heart, He gave women a little extra pad of fat on our belly from the very beginning to protect our bellies during pregnancy. Unfortunately, that fat doesn't go away. So you can have the best abs in the entire world, but we're still going to have that little middle belly. Exercise, weight management, all of those things can make a big difference. Sometimes we have to do the spandex. Sometimes, you can be very, very slender, but still have that little bit of a pouch. It is what it is. What can I say? Do the best you can. Migraines. Many women will have migraines associated with their menstrual cycle. We call them menstrual migraines. And many times as women transition, they will, because hormones are so erratic, all of a sudden have this real increase in migraine headaches. Many times then, once they go through menopause, they're not having the ups and downs of the estrogen and progestin, then all of a sudden the migraines really improve. So that can make a difference. But that's one issue. There are many reasons for migraines, that kind of throbbing, pulsating headache that women get. But again, that can make a huge difference in, again, how we respond, and sometimes there's relief in going through that. Surprisingly, depression or mood changes can impact women during this time. Again, it's kind of an unsettled time, and along with the hormonal changes, sometimes we're experiencing empty nest or adult children coming back home to live, or downsizing our home, or caring for an elderly parent. Many of those things can impact on how we're responding to things. So we want to keep in mind that we're a little bit more vulnerable and more likely to experience it during this time. but it's manageable. And sometimes behavioral therapy, medications can sometimes help. Lifestyle or stressor controls can also make a big difference for people. Okay, so brain fog. I think a lot of times there's that distractibility that we experience sometimes going through this period of time for a number of different reasons. But the reality is many of us question, oh my gosh, I'm like forgetting names, I'm forgetting numbers. I'm the Post-it queen. I have Post-its everywhere in order to help me to remember to do things or that I have an appointment somewhere. And there's a concern that maybe we're developing dementia or Alzheimer's, those kinds of things. The reality is it's usually just very transient as we get through it. It's very unusual for something like that to develop in midlife. If you have specific concerns, though, certainly, again, work with your healthcare provider and we can have further assessments on that. But again, nothing to be overly concerned about as far as that's concerned. Most menopausal symptoms, again, can be managed. So I want you to be aware of that. Even without treatment or intervention, we kind of move through it. As I mentioned before, some women go through it with very few symptoms. Other women, it can be much more debilitating for them. Some have no symptoms at all. So we all approach this a little bit differently, and you have to decide if any of these symptoms are significant enough that we need to manage during this transition. Certainly there are things that as we go through and get into menopause that are more significant, and so we need to address some of those things too and talk a little bit about some of the screening mechanisms that we need to really pay attention to as far as females are concerned and address those issues so that we're staying as healthy and as vibrant as we possibly can. Cancers are a big one, obviously, and we have a lot of concern about cancers. Breast cancer is probably our number one concern as females, and I think it's because the breast itself in our society has kind of been epitomized as the biggest part of femininity, and so we're concerned about that. But the reality is that cardiovascular disease far outweighs breast cancer as a risk factor, but we'll still address that. Cancers occur and continue to increase in frequency as we get older. You know, I mean, our genes just, everything is starting to get a little bit of wear and tear on it, and so we just don't recover as quickly. So ultimately in our lifetime, there's a 1 in 3 chance of developing cancer in our lifetimes. Menopause doesn't increase the risk, it's more age. There are non-modifiable and modifiable risk factors for most cancers. Non-modifiable, or those that we can't change, include age, race, and family history is a big one. So it's real important for you to know as much about, especially immediate family history, as you can. Cancers, heart disease, diabetes, those kinds of things that we need to keep in mind because our screening mechanisms would change based on family history. Modifiable risk factors include obesity, alcohol consumption, and basically when we talk about moderation for females, alcohol consumption is considered moderate if it's 1 drink a day. Most healthcare providers are going to tell you that's too much. So keep that in mind, but it's something that we can modify if it looks like that's impacting on what's going on. Exercise, ideally 150 minutes weekly of moderate intensity aerobic exercise, or 30 minutes a day. Moderate intensity is considered brisk walking. 75 minutes a week if you're high intensity exercising. And for women, not only do we need aerobic, we need weight resistance. 1, for our bones. 2, we lose all of our muscle, especially upper body. And so as we lose muscle, we lose strength overall, and we want to make sure that we're at least balancing out some of our exercise. Nutrition, obviously we can all take a look at nutrition. it impacts significantly, especially the United States or American diet that's high in fatty foods, processed foods, red meats. The Mediterranean diet is really, or a DASH diet is really a great way to go, where you're doing more plant-based diets, low sodium diets that can help with diabetes, cardiovascular disease, and a number of things. Socioeconomic status makes a big difference too, surprisingly is being modifiable, because I think a lot of times it will impact on exercise, nutrition, obesity, and a number of things. Number one modifiable risk factor, smoking. Quit or keep quitting until you finally do quit. We've come a long way. Unfortunately, what we've done in many instances is replaced cigarette smoking with vaping or electronic cigarette use, and that in fact is probably, and I think it's going to finally pan out that we're going to find that that's doing more damage than the actual cigarette smoking. So while we thought it was maybe a substitute to cigarette smoking while we tried to quit, it's just as addictive because it involves nicotine. So watch that and try to minimize that a little bit. Okay, breast cancer. Breast cancer, when I first started in this field, I worked in a breast cancer detection and education program. And at that time, the risk for breast cancer was 1 in 12. Now it's 1 in 7 women who will be impacted by it. And a lot of it has to do with the aging population, as I mentioned. But fortunately, the mortality rate for breast cancer has dropped significantly because of early detection, intervention, and good changes in treatment. I recommend that if there's no family history of breast cancer, maternal side primarily for females, mother, grandmother, sister, that kind of stuff would be significant. Annual mammograms should begin at age 40. And then annually thereafter. No one likes to have mammograms, and there are some wonderful YouTube programs that tell you exactly how to prepare for your mammogram these days, which is terrifying, and why some people don't go. It's not that bad. It saves lives. Along with that, you should have also a regular clinical breast exam once a year. That's by a healthcare provider who understands what breast tissue feels like and can supplement the mammogram report and your input. Breast self-exam, it's become more controversial, but the reality is women need to know their own bodies, and most of us do. And so by checking your breasts, either very formally, laying down, doing the whole thing, or just casually checking when you're bathing, know your body. Know what's normal for you. You'll pick up abnormalities, and then take that and get that further evaluated. Endometrial cancer, which is uterine cancer, we're seeing many times a little bit more, probably menopausally, the number one symptom that's going to trigger an evaluation for the postmenopausal bleeding is uterine cancer. If you're bleeding postmenopausally, my flag goes up to say, okay, we need to evaluate this. Pelvic ultrasound, endometrial biopsy. The reality is it may not be cancer. It may be a uterine fibroid. It might be a polyp. Those are the kinds of things we want to identify and we can manage. If it's a uterine cancer, typically it will lead to a hysterectomy. But again, we're catching it early. We can save your life. You lose your uterus, but you can continue on without a whole lot of trouble. Cervical cancer. Worldwide is still a very significant problem. In the United States, with the screenings that we do and the introduction of the Gardasil vaccine, which typically is administered at age 11 or 12, the Gardasil vaccine is an HPV vaccine, and we know at this point that HPV, the human papillomavirus, is what causes most cases of cervical cancer. If we can eradicate that, we can virtually really decrease the number of cervical cancers we're seeing. My recommendation at this point for pap smears, which is still recommended for women is you begin to have your first pap smear at 24, regardless of or at 21, regardless of whether you're sexually active 10 years before. Please don't be 10 years before. But again, 21, just because the prevalence of HPV is so significant that we're picking up HPV at that age, in that age group, and then you have to address a problem that usually is just locked down and removed by the immune system, and it's cleared. Pap smears, regular, just plain pap smears from 21 to 30. At age 30, we introduce co-testing with an HPV test, which tells us the presence or absence of HPV and how we need to manage that woman. If the pap smear is negative and there's no evidence of HPV, I usually will recommend every 3-year paps, but continue with an annual pelvic exam. Some physicians are doing every 5 years. I'm not quite ready to make that adjustment. So I'm still recommending every 3 years for a pap up until age 65. If your pap smears have always been negative, at 65 you can discontinue them, or certainly if you've had a hysterectomy prior to that, we don't need to do pap smears because you don't have a cervix. Ovarian cancer is a scary one for many of us, only because the symptoms can be really kind of subtle again, and many times by the time we are identifying ovarian cancer, it's at its late stage. So again, family history is a key. Smoking is also a key. Those are the things we want to really key into at this point in time. Lung cancer, number one, most lung cancers, 90% of all lung cancers come from smoking. So if we can eliminate the smoking, we can. But again, 10% probably are non-smoking lung cancers. And so again, family history, pollution exposure, asbestos, radon, anything like that that can increase lung disease is something we would want to monitor, and we can do that with a low-dose CT of the lung periodically just to make sure everything is okay. Colorectal cancer, kind of been in the news a little bit more. The American Cancer Society and the Gastroenterology Society have also now recommended that we begin screening at age 45 rather than 50. We're seeing younger colorectal cancers again associated with our diets, lifestyle. Family history is huge. That's something that you want to zero in on, and if there's family history, start that. Make sure that you're going in for that baseline colonoscopy at 45. We do have a couple of options other than the colonoscopy. One is a new blood test that's just come out. Insurances are not really keen on this one right now, but it is something that is available. It's not readily marketable at this point in time. There's also the Cologuard, which basically is the poop in the box. You they mail you the little box to your doorstep, and you deposit your specimen and send it back to the post office. If that comes back and it's only negative or positive, but if that comes back negative, then you're good for 3 years. If it comes back positive, you go to colonoscopy. If there's family history, if there's a history of rectal bleeding, if there's a history of irritable bowel syndrome, those people really aren't the best candidates for the Cologuard or the blood testing. You should be evaluated with the visual inspection of the colon with a colonoscopy. Skin cancer, many of us are a little bit older. I don't know about you. It wasn't a good day in the sun when I was younger unless I got really toasted. And I mean, there was the foil, there was everything. So many of us have had skin burns, and that is going to increase our chances of, one, aging, but two, the skin cancers. Squamous and basal cell are the most common. Melanoma, the more deadly. So you want to have, if you're fair-skinned, you're higher risk. If you've had the burns, if there's any if you've got multiple moles, you want to see a dermatologist and get an annual skin check. I think Skin Cancer Awareness Month is in May, and many times they will, the dermatologists in the area will actually come in and do skin checks for people for free. So it's something to take advantage of if you can. We've talked a little bit about cancer. Another risk factor as we go through menopause is cardiovascular disease, cholesterol, blood pressure. Those are the things that we're taking a look at. Smoking, again, is a significant risk factor associated with that. Diabetes, exercise, a number of different things. So we want to just make sure that we're being evaluated regularly and managed if we have hypertension, high cholesterol, diabetes, because those are all, as we get older, going to impact on menopause and how we move through those latter years in our life. Exercise, again, we talked a little bit about weight management, good nutrition. All of those things are real important. Risk factors associated with cardiovascular disease, as I mentioned, almost all of those. And hormone, what is some of the ways that we can manage and improve bone health, vascular issues, vasomotor symptoms, genital urinary symptoms, those kinds of things involve sometimes, many times, hormone therapy. If in fact you have significant symptoms, that's usually when you're approaching your healthcare provider and saying, oh, somebody needs to do something. A lot of times, and I'll talk a little bit about some of the lifestyle things that we can use beyond hormone therapy, but hormone therapy does actually replace both the female estrogen and progesterone. It's the lack of estrogen that many times will trigger all those vasomotor symptoms and the thinning of the vaginal tissue, etc. So those are things that you want to pay attention to a little bit. There are two types of hormone therapy. One is considered to be systemic, which is typically something that's going to impact on the whole body and takes care of a lot of the vasomotor symptoms. That usually is administered either via an oral pill, transdermal patches. There's a vaginal ring that can work for that. Creams, gels, some of it's compounded, some of it's prescribed. There are a number of ways that we can work with that. And that can make a huge difference. The other type of hormone replacement therapy is considered low dose. And that's basically when we're managing those genital urinary syndrome symptoms. So it's a vaginal, low dose, localized response. And I have a lot of breast cancer patients who, even if their breast cancer was estrogen positive, I mean, all of a sudden you've gone through chemotherapy and you don't have any estrogen left because we've given you some anti-estrogen medications and you're experiencing a lot of symptoms associated with that. You can use a vaginal estrogen for that, and that will make a big difference. Many women who have urinary symptoms, painful sex, we can address that too, along with other personal lubricants and vaginal moisturizers and those kinds of things. But recognize, and a lot of these things I'm talking about, it sounds like, oh my God, I don't think I ever want to go through menopause because of all these issues. Most of these are very manageable, and there's kind of a feeling of almost euphoria when you finally get to the other side and you've gone through that transition. So keep that in mind. Typically, hormone replacement therapy is best if started right at the time of menopause. Certainly within 10 years beyond menopause. I don't like to start women if they've been 10 years out of menopause and they're coming in unless I'm starting them on a vaginal preparation. So keep that in mind. That's just something that always we have to address. Some of the risks associated with hormone replacement therapy include stroke, the development of blood clots, uterine cancer, and that typically will, it's sometimes increased if a woman has her uterus but she's not taking progesterone with her estrogen. And what happens is the lining of the uterus can thicken and sometimes turn to a uterine cancer. So we need the progestin to keep that lining thin so that that doesn't occur. Breast cancer, typically we're not seeing breast cancer risk increase until maybe the 7th year of hormone replacement therapy, estrogen only. If you're doing estrogen and progestin, 3 to 5 years, and the risk can increase for breast cancer. But again, with regular screening, regular evaluations, management of those kinds of things, and making sure you're on the right dose of your hormone replacement can make a big difference. So do keep that in mind. Some of the benefits, obviously it's reducing symptoms. Vaginal symptom relief can be really huge. Bone protection, bones love estrogen. And so many times, and some of the data will say, we're not going to do your first bone mineral density till you're 65. Well, you've been maybe 15 years out of menopause without estrogen possibly, and your bones aren't happy. Many times we will see a woman at this level as far as their bone density, and postmenopausally without the estrogen, it will drop significantly before it levels off. So I recommend that we start those bone mineral densities or DEXA scans right at the time of menopause, maybe a couple years after, because I don't want to wait until you're osteoporotic to address your bone health, and then we're trying to backtrack on it. I'd rather address it early, where we can make some lifestyle changes and modify some things to keep you from ever getting to that osteoporotic range. Osteoporosis is basically porous bone, which increases the fracture risk, and that's real significant for women as we get older. And many times the fracture is spontaneous rather than, a lot of times you'll hear, well, I fell and broke my hip. Sometimes it's that the hip broke and you fell. So those are the things that we want to prevent you from ever getting to. One of the other benefits as far as hormone therapy is a decrease in cardiovascular disease. What they feel estrogens can do is keep our vessels, which in females are smaller than men, from it maintains elasticity. So that can be very beneficial too. And for a long time, cardiologists were saying, no, it's a risk factor. There are, if you start hormone replacement therapy 7 years after menopause, it can increase cardiovascular or heart attack events. And so they were saying, we don't want anybody on hormone replacement therapy. And now the data is showing, yeah, there are benefits. So again, it's worth a discussion. If you have cardiovascular disease, you may want to discuss that with your cardiologist just to see if in fact this is an option for you. It also reduces the risk of diabetes. So obviously we have some adverse events. Stopping hormone replacement therapy, that's something that you may want to decide on your own or with the help of a healthcare provider. Some women can just stop and not have any symptoms. Some women need to wean off their hormone replacement therapy so it doesn't trigger some of those vasomotor symptoms that they had in the past. And you can do that either through the course of months. Some women honestly do it over the course of years. And finally they get through it and they're not being as symptomatic. Recognizing again that we can always go to the vaginal components of things if we need to. Some of the other treatments for hot flashes, weight loss, obviously the more adipose tissue or fat tissue produces estrogen. And so again, sometimes we'll look at managing that a little bit more effectively to try and control or at least maintain estrogen levels. Cognitive behavioral therapy can help. Sometimes hypnosis can help. Acupuncture. Women have gone to all kinds of measures to avoid using prescription medications and try some lifestyle modifications. The cooling techniques. We all have the fans we all have fans at our desk. The fan club, everybody. We all know what this is, just a universal signal that if someone is doing this somewhere or they've got the paper up that they're having a hot flash. Dietary modifications, dietary supplements. There are a lot of things out there, including like black cohosh, evening primrose oil, dong quai, a lot of different things. Soy-based products many times will be an option. Usually I will see a good benefit from these introductions if the symptoms aren't real significant. If you're having significant vasomotor hot flashes, night sweats, sometimes you need to do a combination of things. So keep that in mind. Trigger avoidance, alcohol, caffeine, those kinds of things. Spicy foods can sometimes trigger a hot flash. Some of us are a little bit more sensitive. There are medications out there that we do use if a woman can't take an estrogen or chooses not to use an estrogen, maybe because of family history. Paxil is one. Paroxetine, it's an SSRI, or it's an antidepressant basically. And one of the side effects in low doses, it seems to stem some of the hot flashes and night sweats. There's a newer medication out called Veozah. I'm sure maybe you've seen some of the commercials out there. They really pumped up on Veozah during the Super Bowl. I'm not quite sure why we were seeing so much about menopausal medication during the Super Bowl, but yeah, they really took out a lot of ads. It's a newer medication that basically works very differently in a non-hormonal way to minimize hot flashes and night sweats, and consequently, if you're not having all the night sweats, your insomnia improves. So that seems to work very well. You need to monitor the liver fairly closely with the Veozah, but it's very effective. Again, I mentioned Paxil. There are a number of other antidepressants that I've used over the years, again, for women maybe with breast cancer or an early surgical menopause. That Zoloft is one. There are a number of them that you can utilize in a low dose form that seems to work very effectively. Gabapentin is a medication that we use sometimes for neurological disorders. Oxybutynin is basically a medication we use for overactive bladder. Gabapentin and oxybutynin, I haven't seen huge success rates for, but again, everybody responds a little bit differently, so it's definitely worthwhile. Hormone replacement therapy is not recommended to improve cognition as we get a little bit older, but sometimes some lifestyle modifications, maintaining an active social network, staying mentally active. We've all heard Sudoku, do jigsaw puzzles, do whatever crossword puzzles, engage your mind a little bit, and remain physically active as well. Increasing omega-3 fatty acids either through your diet or through supplement. Again, I've mentioned the Mediterranean diet, non-smoking, consuming alcohol in moderation, and managing. If you're diagnosed with blood pressure, many times there's not a whole lot you can do about it. Sometimes it's genetic or family disposition, so you got to manage it. Get your numbers. Ideally 130 over 70 now. It used to be 140 over 90. They really are dialing that back. Same with cholesterol. Same with your blood sugar levels. We're doing more hemoglobin A1Cs now to address pre-diabetes, and we want to get those numbers down, so keep that in mind. I talked a little bit about mood and anxiety. The thing about some women, we're more predisposed. Women are more predisposed to anxiety, and the downside with having a degree of anxiety is that a hot flash can also, as it's starting, mimic a panic attack. I mean, sometimes your heart rate goes up. You just feel out of sorts as it comes on, and so sometimes that can exacerbate your anxiety a little bit more. Sexual issues. This can be a big one for a lot of women as we go through the change. A lot of it just has to do with lifestyle, being in the middle of the life, managing, kids, family, parents, dogs, work, all the stuff. That can be an issue, and sometimes we just want to go to bed and we want to go to sleep and we don't want to talk about sex. Sometimes there's a real decrease in sexual desire. Again, hormonal changes that can impact on the vaginal tissue and discomfort associated with sex, painful sex, burning. Sometimes the vagina, if it can even shorten a little bit, it can even close if we're not sexually active. So, I mean, I don't mean to scare anybody, but again, we don't need to ever let it get to that point, so keep that in mind. Sometimes our partner is going through having some issues themselves. We may have some medical issues that necessarily can impact on sexual desire, and a lot of times this can overlap. We can have difficulty with arousal. We can address that. Difficulty with orgasm, the sexual pain I mentioned. Many of these issues can be treated with estrogens vaginally. There is a suppository of DHEA. There are 3 medications, which I just love, for premenopausal women. So insurance doesn't like to cover it if they look at your age and feel that you might be menopausal, even though you're having some issues. I've worked with a lot of women as far as testosterone introduction, because that can improve libido a little bit, not to the amounts where we're growing facial hair and our voice is changing, but enough to many times improve libido. So that's an option as well. One thing before we go to Q&A is, as we get a little bit older, we need to remember, please practice safe sex. Just because we can't get pregnant doesn't mean that we might not be exposed to sexually transmitted diseases. Use condoms, please. Keep things safe. I've had actually a number of women in their 60s who are in new relationships for whatever reason, and they're coming in with STIs that have to be treated, and they're shocked, to say the least. Let's open it up to questions and answers, because I ran through a bunch of stuff and I know that there's a lot of stuff out there. Yes, ma'am. Mm-hmm. Absolutely. And again, I go with plant-based foods, Mediterranean diet, DASH diet, low sodium. It's going to impact on that a little bit. Trying to stay away from processed foods, red meats, basically, unless they're really lean. Again, you can do minimize the fat content. Higher fatty diets will impact on cancer risk as well. So absolutely. But plant-based is really the way to go as far as minimizing risk both for cancers and cardiovascular disease, and it can overall improve some of the symptoms of menopause. Yes. It used to be 140 over 90. If anything above that was considered borderline above. Now we're looking to get it down to 130 over 70 or 130 over 80. Ideally. It's hard to do that sometimes, but that's where we would ideally like to be. As far as cholesterols, we look at total cholesterol below 200, the LDL or bad cholesterol below 100, triglycerides, which is a circulating fat, below 150, and for women, the good cholesterol, the HDL cholesterol, above 55. So if we can do that, you're in good shape. Above 55. The higher the better. The higher your good cholesterol is, the better. We want everything else to be lower. The good cholesterol kind of cleans out the arteries from the plaque that's developing that the LDL is laying down. Yes. Mm-hmm. Absolutely. Typically, when we're doing a bone mineral density now, we're doing what's called a FRAX risk assessment. And they will give you a number that will tell you your risk for a major osteoporotic fracture within 10 years and a major hip fracture within 10 years. And if your risk is low and you're maybe mildly or moderately osteopenic, I'm going to work primarily on lifestyle, weight-bearing exercise, adequate calcium and vitamin D, those kinds of things. If you can do estrogen, I would say you may want to consider it if you're still within that window. There are a number of medications. Once you're getting to, if your FRAX risk assessment is showing me that you have a 20% risk of a major osteoporotic fracture and a 3% or greater risk of a hip fracture within 10 years, I'm starting you on treatment. Treatment can include oral medications. Insurance likes you to kind of do the step thing. Fosamax being one. There's monthly, there's weekly, there's different dosing. The downside to the oral medication is that it can be very disruptive it can cause some esophagitis or erosion of the esophagus if not taken properly. So if you already are taking something because you have heartburn or gastroesophageal reflux disease, that may not be your best choice. There are medications now, and a number of them that I've used most commonly are Prolia, which is a twice-a-year injection. I've seen really good results with that. Typically, you need to be diagnosed with osteoporosis, though, at that point, and maybe failed tolerating alendronate or the Fosamax because you couldn't tolerate that oral medication. The other one is a once yearly IV infusion called Reclast. There are a couple of others out there, but those are the most common. Reclast is a bisphosphonate, just like the alendronate or the Fosamax. The reality, though, is it bypasses the gut, so you don't have that kind of side effect associated with it. I look at the FRAX risk. I look at family history. I look at, if you're thin, if your frame is already small, you can't afford to lose much ground. Japanese or Oriental and white, especially Irish, fair-skinned women, typically are higher risk for osteoporosis. Hispanic and African Americans usually have a heavier skeleton, and so they usually do a little bit better. Bone densities, insurance will only cover it every 2 years. And the reality is if we're initiating treatment, it sometimes takes 2 years to appreciate any improvement. And if we've started you on a treatment, I am happy with stability 2 years later. If you haven't lost any ground, I'm like, okay, we're doing good, depending on where you're at when we first get that. But otherwise, yeah, every 2 years. For the bone density, again, I usually will say menopausal. Within 2 years of having that last period is when I like to do my first one. And then it kind of all comes down to how you code, how the provider codes the test. And so there are certain things that they'll automatically cover. I say start it. I want to catch you early. I want to catch you when maybe you're a little osteopenic rather than, okay, now you're 65 and we've got some major concerns here that we. She already had it. Yeah. So the earlier the better with a lot of things. Yes. Uh-huh. It's in general, because a lot of times you can use that for some of the vasomotor things, but a lot of times it could be associated with mood, with depression, with anxiety. A lot of it's, for us, for women, it's taking control. If you can take control of something and you feel empowered by it, you're feeling a little bit better. And so sometimes by trying to manage some of the symptoms you're having with some of these alternatives, whether it's to improve vasomotor symptoms, whether to improve mood, depression, anxiety. Hey, give it a try. Absolutely. But a lot of that list was vasomotor. Yes. Uh-huh. Palpitations sometimes come. It's almost as I said, sometimes like with a panic attack or an anxiety attack, you'll get palpitations and it can mimic the hot flashes, the night sweats, some of those changes. So palpitations can occur and it's kind of very unsettling. I would say typically rule out that there's no cardiovascular issue, maybe get the EKG, whatever, do an echo, and then address those things. But a lot of times, again, it's breathing, it's settling things down, and it's managing the symptoms that may be triggering the palpitations. Oh, yeah, absolutely. Absolutely. But you don't want to say, oh, it's menopause, and then find out that it wasn't just menopause. Yes. It's a hormone. Absolutely, check the hormone or check the thyroid as well. You would want to do a workup actually, because sometimes palpitations can be from iron deficiency, anemia, the thyroid issues, hormonal issues. Thyroid hypo or hyper has a tendency more to cause palpitations, but that should be part of a routine panel for you. Okay. Yeah. I mean, it could be that that's what it comes down to, but yeah, absolutely. You just don't want to overlook anything. Omega 3s are good. Your vitamin D, your B12 is good. B complex is also good. I like those. A multivitamin, you only get small amounts in a multivitamin, or you'd be taking one the size of, a chair. But sometimes I don't think I would prefer that we get most of our vitamins and minerals through our diet. I really would. And you can easily. But at some point, I mean, we live in Michigan. Most of us are vitamin D deficient. We've been inside for God, it seems like forever. But again, most of us would need a vitamin D supplement. That can and B12 can also impact as well. So those would be the ones that I would suggest. B6. Any other questions? Mm-hmm. Actually, what I usually will do is if you're perimenopausal, if you're still kind of having periods, I usually don't do any hormonal testing because it's only a moment in time. It's when you have stopped having periods, I will then make sure, let's see where we're at. Let's see where we're at and then go from there. And if you're menopausal and you're not symptomatic, you have options. Yeah. I mean, sometimes women are checking hormones for fertility, for other reasons, for polycystic ovarian, for regular periods. Sometimes we're doing that, and there's a reason for that. But to check for if you're perimenopausal, if you haven't gone, there's no point in checking hormones or menopausal hormones. Yes. Mm-hmm. Mm-hmm. Well, I mean, the reality is many times you will have a primary care physician who's kind of coordinating that. As a women's health nurse practitioner, I need to know your history. I want to know where you're at. I want to know family history. I want to know menstrual history. I want to know menopausal history. I want to know lab work. Am I dealing with cholesterol issues? Do I have high blood pressure issues? Do we need to address weight? Those are all things that we need to know about. So yes, absolutely, it's something that if you're and many times the gynecologist will do it. You have to find the person you can work with. Anything else? Thank you for coming. I appreciate it.